entitled What's New with Neurointerventional, sponsored by the Arizona State Chapter of ARIN. My name is Noelle Bradbury, and I'll be hosting today's event from the ARIN National Office. Before we get started, I want to review a few tips to help you enjoy and participate in today's web event. For our online audience, the viewer window on the left will allow you to see everything the presenter will share on their screen, and the control panel at the right is how you can participate in today's event. This is where you will type in any questions that you may have, and our speaker will respond to questions in the last few minutes of the presentation. This webinar is being recorded, so the phones and our live audience will need to remain muted throughout the presentation. To access your contact hour certificate, please refer to the online course confirmation email you received from ARIN when you registered. You have up to 1 year to complete the course evaluation and to print your certificate. Also, your handouts can be retrieved from the same location within the ARIN LMS as well. It is now my pleasure to introduce our speaker for today. Dr. Peter Sonnenschein trained at New York University within a combo residency program doing neurology, radiology, and neuroradiology, only to be followed with a fellowship at NYU during neurointerventional surgery. Dr. Sonnenschein is board certified in both neurology and radiology and has worked for some time for a private practice in Scottsdale, Arizona. Now working for Banner Healthcare in their flagship hospital, Dr. Sonnenschein has a main focus in NIR procedures. Welcome, Dr. Sonnenschein. Dr. Sonnenschein, we are having some difficulty hearing you. If you could select the telephone option under your audio tab on your control panel. At this time, we are having some technical difficulties, but we will begin momentarily. Dr. Sonnenschein, you may need to call in using your cell phone if that is possible. At this time, we are unable to hear you, and we will resume momentarily.
Hello?
Hi, Dr. Sonnenschein?
Yeah.
Excellent. Okay, I believe we can hear you now. Perfect.
Okay.
Okay, well, all right, go ahead.
Did you hear any of what I was saying before? Or was it?
No, unfortunately, we did not catch the very beginning. So.
Okay. I'll just start over again. I want to thank you guys for inviting me, and to the ARRN for inviting me. I think it's real important to understand that neurointerventional surgery is certainly a team sport, and without the nursing staff having a really good idea of what's going on in the angiography suite, it certainly makes the physician and the technologist's job much more difficult to try to concentrate on all the things that they're having to concentrate on. So I'm hoping to provide a basic understanding of what the field of neurointerventional surgery is and what kind of procedures we offer and the equipment and devices, and also give an overall idea of the fundamentals of patient care. So the things I'm going to go over are neurointerventional. What is neurointerventional surgery? An overview of the care during the case as well as after the case, and some of the equipment that we typically use, and then some of the procedures and disease states that we might take care of. Neurointerventional surgery goes by many names. Some people call it interventional neuroradiology, endovascular surgical neuroradiology, neurointerventional radiology. I mean, it was developed in the 1980s by neuroradiologists. Interventional neuroradiology was the term that started, but nowadays it's practiced by neurologists, radiologists, and neurosurgeons. And recently our society changed its name to the Society of Neurointerventional Surgery, so in general that's the term I use. It's undergone a rapid evolution since the 1980s, mainly because of technology and equipment that's developed. Mainly it's procedures with catheters and needles in the brain as well as within the spine, performed under radiologic guidance. Generally, the procedures we perform are minimally invasive, and we treat disease states such as stroke, aneurysms, and venous disease. So a little bit I'll talk about the care of the patient during the procedure, specifically what a radiologic nurse might do during a neurointerventional procedure. Most of the procedures are performed with a biplane unit, which is the unit you can see here. There's many neurointerventional procedures that become very difficult unless you can see things in two planes at once. So most places nowadays will have a biplane unit for neurointerventional. So pre-procedure, the things that I would expect or hope to get from the nurse, and that doesn't mean the physician isn't supposed to have to perform these things as well, but certainly vital signs would be a very key component of the pre-procedure workup. Allergies that the patient has, any medications they're on, especially blood thinners. They'll all need a CBC. You'll need to know the platelets, certainly a creatinine, PT, PTT, INR, pretty typical stuff for radiology procedures. Past medical history, a lot of times the physician doesn't end up getting that, but it would be important to know, is the patient diabetic, how much are, in regards to what the risk is of having renal insufficiency. A basic neurologic exam, and I'll go over that in a second, but just a basic neurologic exam by the nurses can make all the difference in the world. And as with all interventional procedures with angiography, you always have to document the distal pulses. Not just take them, but document them, because these procedures can be 6-8 hours long, and you may be switching out with somebody else by the end of the case. So one of the things that we use quite often in neurointerventional is general anesthesia. So the nurse's role changes depending on whether there's an anesthesiologist in the room. Obviously, if there's an anesthesiologist, the nurse doesn't have to worry so much about monitoring the patient, but their help is always appreciated with regards to vital signs and the neurologic examination. They should be the one helping watch the patient if they are not under general anesthesia. If they're under general anesthesia, there's really not much of an examination that you can do. Even the pupils are not going to be a reliable determinant for what the neurologic status of the patient. When somebody's under general, the only real way to see how they're doing neurologically is through the angiogram. But certainly when they're under moderate sedation, you want to be constantly having a conversation with the patient to make sure that they are awake, they're still communicating with you, and that they're still able to talk. IV drips are a crucial part of neurointerventional. While it's certainly always good practice to make sure there's no bubbles in any IV lines during regular body interventional cases, with neuro it becomes that much more important. You may have 3, 4, 5, 6 drips running at a time going into arterial catheters, and those drips need to be pressured up, and there needs to be no bubbles in them. And if one of them runs out, there's a good chance that some air is going to go through the line before you pick it up. So making sure that those drips always have appropriate volume is very important, and that they stay pressured up so that you don't get, so they're doing their job and that blood flow doesn't come back in the catheter. We use a lot of medications in the neurointerventional procedure as well, which I'm going to go over those specifically. So some things that would be important to notice on the neurologic exam would be pupils, first of all. That's one of the few things if the patient does not have a good mental status at the end of the procedure that you can actually check. So, and at least I'd say about 7% of people have a normal underlying anisocoria or an asymmetry of the pupils. And that can be very scary if you didn't document that before the procedure. So pupils are a really easy, really simple, objective neurologic thing you can check. Baseline mental status is always important, and it can be very subtle. So you really want to check with the patient, make sure they are oriented, and that they have no problems with speaking or naming. And just having a simple conversation with them will tell you often about that, but they are very confused, and unless you ask them the orientation questions directly, you certainly can be fooled. Weakness can be tested with a simple drift exam, having the patient extend their arms, palms up, having them close their eyes, and seeing if one of the arms goes down, drifts down. And then you can test the legs. You can even just do a distal exam with the foot. And it's very easy to just touch them on both sides of the body and their face, arm, and legs and do a simple sensory examination. Some medications that we typically use are blood thinners. Heparin is the most commonly used in the interventional suite. And certainly protamine, which I will go over in a second, is you have to be aware of. That's the reversal agent for heparin. I'll often use rectal aspirin if the patient is still too sleepy to take aspirin. Aspirin is still the best antiplatelet agent out there and works very well and is fairly well tolerated. We also do vasospasm treatment. Almost always in neurointerventional we use calcium channel blockers for vasospasm treatment. Verapamil is the one that I use the most. Some people still use, or some people believe in cardine. That's more longer acting. Nimodipine, it only comes IV in Europe, but it's the only oral medication that's proven to help prevent vasospasm. So that's a good one to be aware of as well. This is a picture of somebody who's in fairly severe vasospasm, especially in the anterior cerebral artery. Nitroglycerin most often is not used in the intracranial circulation because it is so short-acting. Some medications that we also use are the thrombolytics. A real important one during the procedure is going to be the T2B3A inhibitors like ReaPro and Integralin. And those are very good for an acute thrombus or embolus that forms during the procedure because those actually keep platelets from aggregating on themselves. TPA actually prevents fibrin from forming, and that's for a little bit, for a clot that's a little bit older, still acute, but probably within an hour or two, and that's why we use that for acute strokes. And TNK is also actually a tissue plasminogen activator. It's TPA is actually a generic term for that. It actually binds to clot better, and I think in the future we may end up seeing that more used in stroke as well. Right now it's used in the periphery a lot more, but I've started using it in dural venous sinus thrombosis and other procedures, and it works really well. So heparin, typically in the neurointerventional suite, given an IV bolus around of 1,000 units to 5,000 units. Some neurointerventionalists draw ACTs to see how well the heparin's working and bolus accordingly. It's always drawn from an arterial line or a groin sheath. Supposedly, the heparin affects the ACT within 2 minutes of the bolus. But when you, within 2 minutes of the bolus, but most people draw it around 5 minutes or 10 minutes after each bolus. And then once you reach the goal value, which is 250 to 300, people draw generally every 45 to 60 minutes. I use rectal aspirin again when the patient does not have a mental status to be able to take oral aspirin. I usually give 300 to 600 milligrams, often right after a procedure, and sometimes I give it daily, sometimes I give it more often than daily. Usually a dose of 300 to 600 milligrams daily is plenty. Protamine, this is one of the most critical drugs to have in the angiography suite that is often overlooked. You always want to be prepared for any kind of emergencies. And the first thing that you would do if something goes wrong in the head is, if there's a rupture of an aneurysm or any kind of vessel injury and there's a bleed in the head, is reverse the heparin. That's the most basic and easy thing you can do. So in my practice, I always have the anesthesiologist have drawn up a full syringe of 50 milligrams, which is supposedly the maximum dose. You're supposed to give it slowly, but in general, I will have my nurses or anesthesiologists give it quickly because we don't have time to drip it in slowly. You really only have a few minutes before the patient's intracranial pressure reaches a problem point. So you just push it in and reverse the heparin as soon as you can. And I will always have that in the room no matter what, just in case. Verapamil is the drug I like to use for vasospasm. It also comes in 10 milligram vials and at a dose of 2.5 milligrams per cc. I usually dilute it 1-for-1. It doesn't matter how you dilute it in the NeuroIR suite, but it is important that you dilute it the same every time. If you use a drug so commonly, it's important that it always comes in the same volumes per milligram so that there's not any dosing errors. It's almost always given intra-arterially by me, so I'll usually have it on the back table. And I use it for even general procedures to get rid of vasospasm that's often catheter-induced. And you can give anywhere from a couple milligrams all the way up to 30 or 40 or 50 milligrams per artery. It really doesn't matter. The only limiting factor for the amount of verapamil you give is the systolic blood pressure. And once that starts dropping, then you're at your end dose for verapamil. Nicardipine is another drug that we often use for vasospasm. It's a much more potent drug. Usually comes as an injectable of 10 cc's at 2.5 milligrams per cc, or you can get it in 20 or 40 milligrams per 200 cc's normal saline. I'll have this diluted usually 5 milligrams in about 50 to 60 cc's. The reason I dilute this so much more is because you have to give this very, very slowly because it tends to drop the blood pressure by a lot. So I almost never use this for intra-arterial vasospasm unless there's an arterial line in monitoring the pressure as you go. And I don't like to use it as much because it drops the pressure so much. Generally, the pressure comes back fairly quickly, but in somebody who's in vasospasm, the whole idea is to keep their blood pressure up during the case, so you're actually being counterproductive by dropping their pressure. The GP2B3A inhibitors I spoke of, like ReaPro or Epciximab or Integralin, or the word that I can't pronounce, efzofitimide, are great drugs if an acute thrombus forms or if any clot is forming on coils that you're using during the procedure. Usually it's given as a bolus intravenously. And then I often ask for the bolus is actually given by me often during the intraarterially. And a drip is started intravenously by you, or by the nurses, or by the anesthesiologist. And I apologize. Excuse me. The bolus is often given by me. I'll either give a full bolus of 2 micrograms per kilogram per minute, or a half bolus of 1 microgram per kilogram per minute. I usually like to use integralin because platelet function is generally restored more quickly after stopping the medication, about 4 hours after stopping the med, whereas Riapro is going to take about 72 hours for normal platelet function to return. Alteplase, or TPA, comes in as a 50 or 100 milligrams of powder. Comes with a diluent to make it 1 milligram per milliliter, or Taflo is 2 milligrams in 2 milliliters of sterile water. Generally used for thrombolysis for acute stroke, but like I said, G2B3A inhibitors are used for hyperacute stroke. The weight-based dose, officially 0.9 milligrams per kilogram, and then 10% of that is given as a bolus, and the other 90% over 1 hour. Sometimes during the case, I will use TPA, generally not in combination with a G2B3A inhibitor because that's a really potent blood thinner. But often I will ask for no more than 10 to 20 milligrams of that to be in the room. So all of these medicines are generally used in emergencies as well. There's important equipment you should know about should things go wrong in neurointerventional. When things go wrong in neurointerventional, it's generally a very bad thing, and you generally don't have a lot of time to fix it because the head is a closed space, and unlike open surgery, you really don't have access to stop any bleeding or to reach in there and pull out any clots that form. So you've only got a short amount of time to fix whatever problem you cause, and certainly you won't have time to send them to the OR for them to do an open surgery to fix it. So some important equipment that we might use would be NBCA or glue, onyx, coils, balloons, rescue devices like the one I showed here is called the alligator snare, and then a normal snare at the bottom, a normal loop snare. It's actually a micro snare. Certain medications that I said, like protamine, you're going to want to have on hand and in the room. I always ask my nursing team to have integralin, know the weight-based dose, and have it in the room, even if they don't open it. Should know a code team phone number, and should know how to get a hold of neurosurgery. So even if you don't scrub these cases or you never circulate these cases, you should definitely know what these things are at least, and maybe generally where they are in the suite. So if everybody's running around trying to fix the patient and the physician asks for one of these devices, that you can quickly get it. So some of the risks of angiography or neurointerventional procedure. Certainly the worst thing that can happen is a stroke or a brain hemorrhage, and if that does happen, often it can be fatal. It's very difficult to treat once it happens. Strokes are a little easier to treat than a hemorrhage. I'd say the chances in a diagnostic angiogram of having a severe stroke are actually pretty low, less than 1% for most neurointerventionalists, probably on the order of 1 in 700 or 800. Can it be anywhere from 1 in 500 to a really elderly patient with really bad vessels to 1 in 1,000 in a young patient? Now, for interventional procedures, the risk varies with the difficulty of the procedure. Most unruptured aneurysms, the risk of stroke is probably on the order of 2 to 3%, which is a reasonable risk, even though it's minimally invasive. There's still probably a 1 in 30, 40 chance that for every 30 or 40 patients you're going to do that are going to have a large stroke, and that's ultimately, when you're doing a lot of these procedures, that's a lot of patients who may not do well. So it's important to keep in mind that it is a dangerous procedure. Vascular injury can occur, like any angiogram, bleeding or infection, anytime you put a needle in the body. Peripheral emboli occur. They probably happen all the time, and they usually don't cause an issue. The contrast can cause a reaction or renal insufficiency, especially in diabetics, which is why we check the creatinine. Certainly, there can be an access site injury or a closure device injury. And I always tell the patients about that beforehand. And one of the different things that can happen in neurointerventional is catheter entrapment whenever you're using glue or onyx. It's important to remember to tell the patients that there's always a chance that the catheter can be stuck. If that happens, we usually cut it off with the groin and leave it in the patient, put them on antiplatelet agents, and it usually doesn't cause a problem. I've had patients around for 20 years before that I've seen in fellowship that have had the catheter just grow into the blood vessel wall, and it usually doesn't cause a problem. One of the things that I will look for post-procedure, I'm going to talk about post-procedure care now, is blood pressure control. So these are things that you're not going to be actively in the ICU probably taking care of these patients, but these are parameters you might want to pass on to your colleague who's going to be taking over the patient. Ask the physician what their blood pressure parameters are. Some people I'm going to want to keep low with a carotid stent or with an AVM embolization in general. You're going to want to keep the blood pressure low afterwards so that they don't have a breakthrough bleed. You might want to keep somebody high after aneurysm treatment, especially if they're already in the vasospasm period, which happens about 7 to 10 days after the aneurysm rupture. Or in somebody who you're leaving some residual stenosis, you're going to want to keep their blood pressure high to help perfuse the brain. Once you do a stroke, you're going to want to try to balance between those two, between a high and a low. You're not going to want to over-perfuse or under-perfuse. Somebody like that, you might have real tight control. And there are many procedures we do that it's just not that important. Tumor embolizations, epistaxis, or nosebleeds. In those cases, there's really not a set blood pressure. One of the things we're going to want to do after the procedure is keep the intracranial pressure low. We'll use antiemetics because certainly if somebody is vomiting, that's going to cause an increase in intracranial pressure. Anti-epileptic drugs for to prevent any seizures. Steroids for any acute edema or pain. All those things will help keep the intracranial pressure low, which is going to help keep the any swelling from any injury that's already occurred. Neurochecks and groin checks are crucial. I'll talk about those in a second. Blood thinners, they'll often be on some blood thinners after a coiling procedure because unlike a surgery, we haven't performed an open surgery, but there is metal, either stents or coils in the blood vessels, and they tend to form clots. So especially the first 24 hours afterwards, we're going to want to keep them on blood thinners. Kind of the reverse of what people are used to after aneurysm treatment. We use DVT prophylaxis, GI prophylaxis, pain medications, all the usual medications and items in the ICU. Sometimes after procedure, we'll have a patient on heparin for a brief period of time, especially after coils or stent placement. It's usually a small dose and often in combination with lytics, such as G2B3A inhibitors. Those are critical after stent placement, and especially if there's clot formation on any coils. I will often run the G2B3A inhibitors for 12 to 18 hours afterwards. And the patient's going to ooze from their site if they're on those. And it's important to let everybody know that that's going to happen. That's okay. There's not a whole lot you can do about it. I'll go over in a second. But you can hold pressure and change the bandages. And once the patient's off those inhibitors, they generally will stop bleeding. It's usually not a pulsatile. Obviously, if it's a pulsatile blood flow, then we have to do something about it. Most of the time, it's just venous oozing. So the number one reason that these patients are in the neuro ICU is for hourly neurocheck. They don't look sick often if everything goes well. They look like they're ready to go home. They're often screaming to go home. But this is a critical time, especially those first 24 hours where clots can form, and they literally go from normal to having a stroke over the course of a few seconds. So it is really important to really hammer into the nurses and whoever's taking care of these patients that they have to do the hourly neurochecks, especially at night. Many are on a lot of blood thinners, and they are at a high risk for intracranial hemorrhage, especially if they do get a stroke during the examination. Groin sheath management. The sheath is already removed. It's typical groin sheath management. Check groin site distal pulses, usually every 15 minutes for twice, then every 30 minutes for some amount of time, and then every hour, and then back to the normal routine. If anything happens, I would want to be notified myself or whoever the call team is of an expanding hematoma or pulses. I always keep the head of bed less than 30 degrees, and whatever extremity you went in straight for 6 hours. If you can, I usually decrease it to 2 hours if a closure device is utilized. Some people can be more liberal with that or less liberal depending on their protocol. Again, many of these patients are on aspirin or Plavix as well as an integral and drip, and they will ooze from their groin site. depending on how fast the bandage gets soaked, I would say if it gets soaked and needs to be changed within a half an hour, then that's something we would have to worry about. But anything less than that, you probably just change the bandage, maybe apply a little pressure. It's really important that you restrain the extremity that has been entered, because if they are not particularly with it or compliant and they move that around, that is going to cause a groin injury, particularly if you leave the sheath in. I'll generally leave the sheath in when somebody who's getting vasospasm treatment, because it's less trauma to leave it in than to actually re-access the artery every day, which often these patients who get vasospasm treatment will be brought down every day if they're only given pharmacologic treatment, because that treatment only lasts for a few hours. That sheath, if it is left in, needs to be flushed every 4 hours. The worst thing that can happen is that clots off and the patient now has a leg problem as well, and that's often very difficult to treat. I generally try to avoid blood draws from the sheath, and the patient has to, again, lay flat or less than 30 degrees, and should avoid laughing, coughing, etc. Can't stress enough that there will be oozing out of the sheath, and it's important everybody knows that, and the physician has to have an idea of what is acceptable and what is not. If there is excessive bleeding that is too much for the physician, then either the sheath has to be upsized or removed, and you trust me, you don't want to remove one of these sheaths if they are really oozing badly and they're on integral, and you're going to be holding pressure for a long time. So it is good if you can tolerate the oozing around the sheath and or upsize it. Sometimes we do venous procedures in neurointerventional. One of them that is called the inferior petrosal sinus sampling, very similar to adrenal vein sampling in the body IR land that many of you have heard of it, except that we sample from the veins coming from the pituitary, and I'll talk about that later. Patient is generally, it's a very easy person to take care of after the procedure. It's just a venous stick, so most people monitor them for maybe 2 hours, maybe even only 1 hour post-procedure. And they, in general, if you're going through the head, you'll keep the head elevated over 30 degrees. If you're going through the groin, then it'll be below 30 degrees. Very few complications from this procedure, except for maybe thrombosis in the cavernous sinus, but generally you don't have a problem from venous sticks. Some of the equipment we may use, we use access devices, closure devices, coils, stents, balloons, embolic material, mechanical thrombectomy devices, and again, the rescue devices that I showed you earlier. Many of you are familiar with the normal access we use in interventional radiology or cardiology: sheaths, catheters, guide wires, microcatheters, microguide wires. These are examples of all of those. In neurointerventional, we use a lot of TUIs or Y valves, often Christmas treed onto each other to allow wires and catheters to go through other guide wires and catheters. We use many different closure devices. My personal favorite is the Perclose device, but this is the Angioseal here. You actually put a little collagen foot plate and then some collagen plug outside the vessel, sandwich them together, and it works actually probably the most reliably, but unfortunately every 700-800 cases that plug will go into the artery and cause a problem. This is called the Star Close, which is a clip-based closure device. It is very easy to use, but unfortunately is not as reliable as the Angioseal, and you'll often get oozing and leaking from this. I try not to use that one. I like the Angioseal because it ties a little suture, leaves almost nothing behind. You can re-access right away, and you can maintain wire access after using it, which is a favorite of mine and my techs, who don't have to compress when the device fails. We can just try another one. We use coils. Coils are generally used to fill up an aneurysm and to keep blood flow from going into it. We'll often use them for vessel takedown. The whole way neurointerventional became a field was the development of the detachable coil, or basically a coil on a stick that you could position and reposition anywhere you wanted, and then detach it at the right moment when you liked the position so that it wasn't sticking out into the vessel. And those were first called Guglielmi detachable coils and came out in the early 90s. Again, they're detachable, usually 1 to 24 millimeters in diameter. We have different kinds of coils: framing, packing, finishing coils. They have all different various diameters, but very small, obviously. Many companies make many different kinds of coils. Some of them have their niches, and some of them are just redundant and really is physician preference. They're often bare platinum. There's been many coatings that have been tried on them to help the aneurysm thrombose and clot off, such as hydrogel or sericite. But in general, those have not worked as well as people have thought. But there's still people or companies trying different coatings out every day to try to promote thrombosis of the aneurysm without promoting thrombosis in the parent artery, often a difficult and tall order. Coils come again in different shapes. This is an example of a helical coil as well as a three-dimensional 3D coil. This is an example of basilar tip aneurysm that's been coiled. Sometimes if the aneurysm doesn't have a narrow neck, it's difficult to keep those coils from going into the artery, so we'll have to use stent assistance. There's only two stents for stent assistance that are approved for in the intracranial circulation, the Neuriform and the Enterprise stent. They are not radio-opaque except for at the distal ends. So they're a little bit difficult to place. They're placed through microcatheters, and you really can't tell what's going on in the middle of the stent, only at the end of the stent. This is called a wide stent technique that's used at the end of the basilar artery to keep the coils from falling out into the basilar artery. This is an example of a carotid cavernous fistula, one of the diseases that you might see in the neurointerventional suite. This is a normal internal carotid artery coming up here, and then actually it just stops, or the normal arterial structures stop, and the rest of this is veins that should be draining backwards into the cavernous sinus, and they're draining retrogradely. This is the superficial Sylvian vein, and here's the ophthalmic vein coming forward. Once the physician recognizes this, there's several ways to try and treat this. This was such a large tear in the carotid artery that, in this case, we had to take down the carotid artery, or actually just close off the fistula by putting coils into it. And we can tell the patient can tolerate this because you can see that all the flow here is not going into the brain. It's all going retrogradely into the veins. And the patient hadn't had a stroke yet, so they obviously would tolerate a closure. This is also a good example of the difference between different kinds of coils. These larger, thicker coils are called penumbra coils. Very soft, great for taking down vessels because you need less coils. And these thinner ones are what a normal 10 coil would look like, and we'll use those for smaller situations. And there's different times we use different coils. This is an example of us slowly taking down the cavernous sinus. Here's what it might look like at the end. You can see it takes lots and lots of coils sometimes to shut down an artery the size of the carotid. And each of these coils can cost anywhere from $1,200 to $2,000 to $3,000. So on a case like this, you can use 50 coils. So these can be very expensive procedures. This is what it looked like afterwards. We can see on a left internal carotid cerebral artery angiogram, an AP view, that now the patient is filling their right side across the patent anterior communicating artery. And that from a posterior injection, we can also see that the posterior communicating artery is filling retrogradely, and the middle cerebral artery territory is filling out. So the patient is doing very well despite losing a carotid artery. If you have a good circle of Willis, you're going to tolerate that well. And then you can also see external to internal collaterals to the eye especially. This is an example of a disease called a dural arteriovenous fistula. This is an arterial injection from the external carotid artery, and what you're actually seeing is a transverse to sigmoid sinus going into an internal jugular vein, filling during the arterial phase. That's the definition of a fistula, is venous blood flow that you see during the arterial phase. In this case, again, we took, you could try to treat these intra-arterially, but this one had too many entry points into the vein to try to treat intra-arterially, so we used coils to close down the vein. It takes a lot of coils. Often the vein is separated into different compartments. You can see that we worked for a long time on taking down just this upper portion of the sinus, and even so, there was still some residual sinus at the end. Kept going with coils, more coils, and finally, this is what a normal extracranial or external artery injection looks like. You can see it looks a lot different than what the dural AV fistula looks like. We use stents and balloons, very small stents, and very soft balloons, but different kinds of compliancy rates depending on the application we're using them for. Balloons can be used for aneurysm remodeling, for opening atherosclerotic vessel, or even for treating vasospasm. or even temporary occlusion. So lots of different balloons. Neurointerventional is one of the few fields that actually has a single lumen balloon where you just put a wire out at the end of the tip, and that causes the port to close with a check valve, and you fill up the main catheter to fill up the balloon. It's a little bit unusual, but it actually works really well and makes for a really compliant balloon. So it's important to understand, if you're ever scrubbing these cases, that if the patient asks for a hyperform or hyperglide balloon or single lumen, any single lumen balloon, do not prep that balloon. Don't flush it with saline, because it can make it impossible to see, because you cannot get rid of the saline and replace it with contrast. For intracranial stenosis, we will use something called the wingspan stent. That's the only official stent for intracranial stenosis. Unfortunately, the Sampras trial came out and showed that the wingspan stent does not work better than medical management. So we're having some issues with how we treat intracranial stenosis at this point. Some people have just used coronary stents, which are sometimes difficult to get all the way up to the intracranial circulation. And some people just treat with angioplasty. Extracranial stenosis, like carotid stent, where carotid stenting comes from, it's kind of in a lull right now, but the CREST data, I think, is encouraging, and I think in the future the technology is going to improve enough that people will be doing a lot more carotid stenting and endarterectomies. They're used for adjunct aneurysm treatment, again, in wide-neck aneurysm to help the coils from falling out. And there's a new kind of stent called a pipeline embolization device, which is a flow diverter. This is actually one of the most exciting ways to treat aneurysms now, without even having to open the head and put a clip across the aneurysm neck or put coils inside the aneurysm. You simply put one of these high-density mesh stents across the aneurysm, and it diverts flow away from it. And then over the course of about 6 months, that aneurysm will close down. It's a really exciting device. It works really well, and you don't ever have to put your catheter inside the aneurysm. We use embolization material. Up top is a picture of something called onyx, which looks like black lava and actually solidifies once it hits an aqueous solution. And on the bottom are particles. Sometimes we'll use polyvinyl particles for tumor embolization or even epistaxis, like you do in the body. It's a really cheap way to embolize something, and still a very good way. We'll use sometimes semi-permanent particulate particles, such as gel foam. We will use particulate materials for preoperative embolization of tumors or AVMs. This is a picture of onyx in a dural AV fistula, and you can see it can be quite extensive, the amount of onyx that you use. Epistaxis we'll often use particles for, and bland particles are suture material people used to use to shut down a vessel quickly. Sometimes liquid embolics are used for aneurysms, as shown in this picture, but that's becoming out of favor now that the pipeline device is out. Generally, they're used for arteriovenous malformations, AVFs, or even pseudoaneurysms where you cannot separate the aneurysm from the artery. You can just take down the whole vessel with a liquid embolic. Onyx is the EV3 or Covidian product, and TrueFill is the Codman blue product. This is an example of a AVM that's being filled with onyx. I'll have that video for you later on. This is what glue looks like, or NBCA. It's actually crazy glue that's made for the brain. And it's an old school way to treat AVMs or embolization. It's a lot more tricky to use. It's completely different from onyx in that the injection is a very quick injection, and it's a very quick removal of the catheter. The entire process takes less than 10 seconds. Whereas with onyx, you actually inject very slowly over the course of an hour or two with slow, deliberate injections. So it's actually the exact opposite of each other. And it's a slow pull as well with onyx of the catheter. So that's why the catheter can get stuck with either one of them, but it's often a more torturous process with the onyx. We also use mechanical thrombectomy devices. An old school device is the Mercy device, which is basically a corkscrew. Here's an example of a clot that's been pulled out with a Mercy device. With the invention of stent retrievers, the Mercy device is kind of falling out of favor, except as a retrieval device for lost objects. The penumbra device is actually a suction catheter, often with a separator inside of it, used to try to suction the clot out. It's a great way to get clot out if it's softer, but if it's harder, the stent retrievers have become the way to go, and they have greatly decreased the amount of time it takes for us to pull a clot out. They're basically stents on a stick, again, but you don't detach them. You literally deploy the stent in the artery and let it sit in the clot and organize the clot into the stent and then pull it out. And it works great. You'll often see large clots come out. This is a stent retriever we used for a carotid T lesion, which can be deadly. This is when a thrombus gets lodged at the distal end of the carotid. You can see a meniscus here where the clot is, and after one pull, you can see there's a completely clean artery, and this patient actually did very well. This is an example of a perfusion CT scan. Many of you will hear of these at least. We often use the CBF map to tell us what area is at risk, and then the CBV map, or cerebral blood volume, shows us what area is already infarcted. This patient has only a small area that's already infarcted and a large territory at risk. So that might be somebody we would go after for a stroke. This is a poor man's view of those two subtracted, showing you the completed stroke and the area of presumed penumbra. Some literature has come out lately that says maybe that's not so accurate, but stroke is a hot topic right now and is being actively debated in the literature of what we should do and when. So keep your eyes open for any updates on that. This is an example of a really tough stroke that came in. The carotid artery is completely blocked right at the origin, and this is just the external carotid artery. The first thing we had to do is figure out what the extent of clot was. The initial injection into or past that stenosis demonstrated a really tight stenosis with clot filling the entire internal carotid artery. A microcatheter was placed distal to that clot into the intracranial circulation, but what it showed us is that the intracranial circulation was still widely patent, which is great news for this patient, meaning that they may have been even getting blood flow from the other side. It's just the carotid that acutely closed. So this is what it looked like after we put a microcatheter across. Still a ton of clot in the artery. Whether you decide to stent first or remove the clot, or remove the clot and then stent, is kind of up for debate. We decided to put in a protection device, which is often what people use for carotid stenting, to try to keep any clot from migrating distally. Then balloon angioplasty the stenosis, then place the stent, and then use a penumbra suction device to try to suck as much clot out as we can. Protection device is still in. We remove that. And then here's the end result. Still a little bit of filling defect in there, a little bit of clot, but the result was actually great in the carotid. The intracranial circulation was wide open afterward. And this is what the patient's diffusion MRI looked like. This is a good indicator of how much stroke actually occurred. All these bright spots are where stroke actually occurred. And it's somebody with a carotid occlusion. This is a pretty impressive diffusion MR with actually minimal signal intensity. This is somebody who will probably do really well. So lastly, I'll go over some neurointerventional procedures that we do for disease space. We will do intracranial aneurysm treatment, as I said. Patients who have a ruptured aneurysm will go into vasospasm, 7 to 10 days peak after their aneurysm ruptures. For some reason, this doesn't typically occur in all brain bleeds. It's just aneurysmal bleeds, very rarely in a traumatic bleed. And we're still discovering why vasospasm occurs and the underlying mechanics of it. But I don't think anybody really knows why that is. Intra-arterial or mechanical stroke thrombolysis we do. We do AVM and fistula embolization, tumors, non-vascular procedures such as vertebroplasties or biopsies, and then more rare procedures like inferior petrosal sinus sampling or WADA tests. Aneurysm is probably the most classic or well-known neurointerventional procedure performed. Generally, the aneurysms are saccular or fusiform meaning involving a long portion of the vessel and involving the 360-degree wall of the vessel. An aneurysm usually represents a weakness in the arterial wall. Many are likely developmental, but there's also environmental factors at play here. The only two factors that really we know that the patient could help or avoid are hypertension and smoking. Otherwise, there's not a whole lot a patient can do to prevent their aneurysm from rupturing, which is why we use very indirect markers to see who's going to rupture and who's not. Location is a big factor. Generally, posterior circulation aneurysms have a higher chance of rupturing. What the aneurysm looks like, is it have a small bleb on it, or is it very irregular? The age of the patient, because these aneurysms have a risk per year of rupturing. If the patient's very old, then it's probably not worth putting them through the upfront risk of treatment. But if they're a very young patient, they're going to have to roll the dice many years before they die. So it might be worth it to take that higher risk up front to treat it. But it also comes down to the preference of the surgeon or the neurointerventionalist. We have very few large-scale trials. The biggest trial for ruptured aneurysms is ISAT, which has basically shown that if you can get an aneurysm coiled safely, in general, you're better off getting it coiled than clipped with open surgery. There's some debate about that, but that's the bottom line. For unruptured aneurysms, we have the ISSUA trial, which doesn't tell us a whole lot about which aneurysm is rupturing, but basically says if it's under 7 millimeters in diameter, there was 0 aneurysms in the trial that ruptured. 7 to 12 is a 1 to 2% per year, and then it just goes up from there. So the party line is that if it's under 7 millimeters and unruptured, you shouldn't treat it, but most of us agree that there's not a magic line in the sand at 7 millimeters, where at 6 millimeters you're at no risk, and at 7 millimeters you're at a 1 to 2% risk per year. So there's a lot of clinical judgment involved. Most of Berry aneurysms occur around the cervical villus, particularly at branch points. Most common are going to be the ACOM, or anterior communicating artery aneurysm, PCOM, or posterior communicating artery aneurysm. Here we are again with a diagram showing where those aneurysms occur: posterior communicating, anterior communicating, carotid terminus, pericallosal, or the anterior cerebral artery, the picas, or the basilar tip is a very common one, where the basilar artery bifurcates in the posterior cerebral artery. Any branch point where blood is going to be pounding into the arterial wall. Here's an example of an ACOM aneurysm, kind of wide neck, but still able to be treated while leaving a lot of the parent artery open. Again, these are penumbra coils, treating the aneurysm fairly well with large, thick coils. This is an example of a middle cerebral artery aneurysm. It's kind of small, spleen-shaped or bilobed, probably only on the order of 3 to 4 millimeters. Classically, middle cerebral artery aneurysms are thought to be better clipped because they're fairly easy to get to, but they can be coiled as well. In this case, the surgeon wasn't available. The catheter easily goes into the aneurysm. You actually get a really nice result post-procedure. There's no filling of the aneurysm, and both arteries are widely patent. We use something called the Hunt and Hess scale to describe a subarachnoid hemorrhage patient. So you'll often hear the doctor asking, well, what grade is the hemorrhage? And this is what he's talking about, a Hunt and Hess grade. Grades 1 through 3 generally don't have a focal neurologic deficit, but actually believe they just have a headache, maybe mild drowsiness. But once you get to grade 4 or grade 5, those people generally don't do as well, and there's often a debate whether you should treat them at all. Grade 4 is going to be stuporous with focal neurologic signs, possibly even decerebrate rigidity. Somebody who's in grade 5, if they're older age, generally we won't intervene on them. They only have a 10% chance of surviving, never mind surviving with a useful life. So many of those never leave the hospital. We use the Fisher grade to describe how much blood clot was actually in the Sylvian fissure of the subarachnoid space. And that Fisher grade will tell you how much risk they are for having vasospasm in the future. For treating aneurysms, there's many different options besides clipping and or following. One is coil embolization, as we've been talking about, stent-assisted coiling or balloon remodeling, or parent vessel occlusion. If the patient can tolerate the whole vessel to be removed or occluded, then we'll often just take down the vessel. That's what we used to do before we had a lot of this great equipment we have. And again, the new treatment option is flow diversion, which has really opened up what we can do to treat aneurysms that were previously untreatable by any means. We use location to determine whether we treat. Again, this is an anterior communicating artery aneurysm, well treated with coils. This is a superior cerebellar artery aneurysm, well treated with coils, very little filling at the end and a nice neck. This kind of morphologic aneurysm is something we'll see in young people. Typically, the aneurysm is involving the MCA bifurcation, and the entire carotid is irregular, blown out, and probably dangerous. This is somebody we might do some palliative care on only if they had a bleed and we don't know where they bled from. Just try to make them as safe as possible, but there's no way to take all this aneurysm. This is a basilar tip aneurysm, very wide neck, very difficult to treat. The small T1 segment on the right, that might be difficult to treat too. That's going to be a little higher risk. It would really depend on how the patient presented, how old they are, and whether they're having problems from the aneurysm. This is a pretty classic bilobe posterior communicating artery aneurysm. We happen to get the framing coil to go into both lobes, which is going to really help anchor that coil and then fill up appropriately. And we actually get a really good result with this aneurysm. Here's what it looks like pre, here's what it looks like post, and then 6-month follow-up. There's no filling in that aneurysm. And what happens is your body actually forms a little skin over the coil-arterial interface, and there's actually no metal exposed. And at that point, if you had them on any antiplatelets, you can stop them. Those stents I was talking about, the Enterprise and the Neuriform, are unfortunately humanitarian device exemptions. They didn't have enough patients to perform the appropriate trials. So patients usually have to sign a very long consent form for us to use them, even though they've been in use for 5 to 10 years now, and they're very safe. They generally do increase the risk of the procedure, but they are very safe. Each one of the stents is a little bit different. The Enterprise is closed cell, so it tends to kink a little more, but it gives you more coverage, and it can be delivered through a smaller catheter, which is very useful for more distal circulation. Again, this is that basilar tip aneurysm using stent remodeling. Here's another Y stent, again with the catheter trapped in place. This is actually a 2-catheter technique where the coils were allowed to intertwine with each other during placement of the stent. Sometimes we'll use parent vessel occlusion if we have no other options. This was probably done before pipeline because this is actually a pipelinable aneurysm. Sometimes we'll do a balloon attest occlusion prior to taking down the vessel. The balloon is inflated over here in the internal carotid artery. And then we actually do physical exam on the patient for half an hour to make sure that they're tolerating the balloon. If they are, we coil front to back, take down a lot of coils. And again, here's the patient filling across the patent ACOM, even with the carotid closed, and also filling from the posterior circulation. I would say at least 40 to 50% of patients will tolerate a carotid occlusion. So let's move on to the pipeline embolization device. This is a very exciting device that's recently become available. We can't use covered stents in the intracranial circulation because there's too many small perforators that come off the vessels. So in the body, if you have a pseudoaneurysm coming off a leg artery or something like that, you just put a covered stent over it and no big deal. Unfortunately, we're talking about very small arteries in the head and very small arteries coming off those small arteries, which are very important. So you can't cover to one side or other of the aneurysm without causing possibly a major or devastating stroke. So the pipeline embolization device is actually a almost covered stent. It's about 30% coverage with the mesh so that it actually, anything that's drawing blood, like a small perforator, will stay open, but a dead-end aneurysm will actually close off over time. This is what we call a parfait sign, from contrast layering and then subtracting out in the aneurysm post-stent placement. This is what the stent looks like. This is actually 2 stents deployed. And you can see the contrast now layering in the aneurysm. Here's that parfait sign, filling slowly out as the contrast goes in. And this is actually what it looked like 6 months later, complete remodeling of the aneurysm. Okay, and here's the pipeline embolization device, or 2 devices. And here's a pre and a post. And it works great for remodeling. This aneurysm would have taken probably 40 to 50 coils to close. And these giant aneurysms like this often will recur. But with the pipeline, we've seen almost no recurrence once it's treated. Complications of aneurysm treatment, as we've gone over before, the worst thing that can happen is stroke or perioperative rupture, and those are usually devastating. Postoperative complications like hydrocephalus and vasospasm occur all the time, which is why you have to work with neurosurgery very closely to take care of these patients. And there's always delayed complications. With the pipeline embolization device, a delayed parenchymal hemorrhage has been described, but it's pretty rare. It's important for the nurses, the patients, and the technologists, and basically all the staff to understand that although this is minimally invasive treatment, make no mistake, this is really dangerous procedures, and any little flip of the catheter can cause major problems. The open procedures are just as risky, but everybody understands that it's surgery. Sometimes that's forgotten with neurointerventional procedures, and it's forgotten by staff when bad things happen. It's a risky procedure, and bad things do happen, and that has to be okay. You have to remember the people that you're helping. And hopefully when this is being done, it's being performed at large centers with people who are very experienced. When a large stroke or hemorrhage occurs, death almost always follows. So, again, you want to try to prevent those things from happening. We talked a little about vasospasm. It usually occurs 4 to 14 days following a rupture. It causes delayed strokes. 25 to 30% of patients who survive a subarachnoid hemorrhage will suffer symptomatic vasospasm, and 10 to 15% of those patients will die or experience permanent disability. So it's kind of the second hurdle that patients have to get over after having an aneurysm rupture. So they may look great after the first day or two, but then you have to keep them in the ICU for at least 2 weeks. The only proven therapeutic option right now for preventing vasospasm is actually giving a pill, nimodipine. So everybody gets 60Q4 of nimodipine for 21 days. Beyond that, nothing else is proven. Most people will make them euvolemic or hypervolemic. Often they will induce hypertension to a systolic of 160 to 200. And then if that all fails and the patient still develops neurologic problems, they will be brought down to the interventional suite and will receive a verapamil through the catheter, or will actually get balloon angioplasty. There's an example of a normal artery on the left and what it looked like during vasospasm. You can see those proximal arteries get very small. These are the kind of people that would get symptomatic. This actually was a stroke that occurred in somebody who had a severe vasospasm that wasn't picked up on time. These are emergency cases, and they need to be brought down as soon as possible so that this vasospasm can be treated. This is an example of what the vasospasm looks like initially, then after 10 minutes after verapamil, and after 20 minutes after verapamil. You can see verapamil actually can do a great deal of in helping the diameter of these vessels. Another thing to treat is vascular malformations. An AVM is a high-flow vascular malformation representing an abnormal communication between arteries and veins. Generally arterializes venous structures so that they get weak and they easily rupture. You also get abnormal blood flow in the brain itself, causing seizures. You can get headaches. Prognosis really depends on size, location, and venous drainage. And there's different ways to treat this, but most of the time you can't just embolize it. You have to embolize and then go to surgery, or embolize and go to stereotactic radiation. Embolization is generally not a cure, but some people treat it as such. Here's an example of an AVM in the cerebellum, which is treated with both coil to treat an aneurysm and then some onyx to try to shut down most of the AVM. We'll use particles or glue sometimes to slow down flow. Again, embolization is rarely done alone for an AVM, but most of the time it's operated on afterwards. And the newer liquid agents such as onyx have really helped us out doing these. Here's a smaller AVM in the parietal lobe. This is what it looks like after an onyx gas has been put into it. The smaller ones you can sometimes treat with onyx alone. Here is a picture of what an onyx embolization might look like. You can see, unlike the glue where I said it was a very rapid injection, the onyx is going to be very slow. We literally push a little bit out every 30 seconds, shut off the fluoro, push a little out, shut it off, and build a plug at the end of the catheter until all of a sudden the onyx shoots forward and fills up the aneurysm. And then even while we're filling up the, I'm sorry, not the aneurysm, the AVM, even while we're filling up the AVM, it's usually a 45-minute injection, or it can be, as long as the onyx is still moving forward. Some of these larger AVMs, oops, got a little ahead of myself here. Sorry about that. Not over yet. We're running out of time anyway. I'm going to run through these last parts very quickly so that we can close up a reasonable time here. Sorry we got a late start. One of the rare procedures we do is inferior petrosal sinus sampling, basically like the adrenal vein sampling. We use to help diagnose patients with Cushing's syndrome. Cushing's disease is caused by ACTH increase, usually pituitary adenoma, which is 70% of endogenous Cushing syndrome. 80% of these will have a high ACTH, and it's often really hard to find that pituitary microadenoma. Sometimes it's less than 1 millimeter in diameter. So MRIs can be normal or inconclusive. So this test helps diagnose whether somebody has a microadenoma. We'll often give desmopressin to help stimulate it to make the test more sensitive. Desmopressin is not a drug to be scared of. They use it in the neuro ICU all the time. It's basically antidiuretic hormone. So you can observe for signs of hyponatremia, headache, nausea, vomiting, restlessness, confusion, but I very rarely see any problems with desmopressin. Most of the time, if they have them, it's because they're dehydrated from being NPO and not the desmopressin itself. We use bilateral venous groin sheath. The most severe complication from this is typically thrombosis of the cavernous sinus. It's kind of hard to hurt somebody doing an IPSS. This is a picture of the catheter going up into the internal jugular vein. Here's a microcatheter going up into the inferior petrosal sinus. You know you're in the inferior petrosal sinus because it crosses the cavernous sinus. And here's a lateral view of that, again, coming up the IPSS, cavernous sinus being filled retrogradely. The last test I'm going to go over is called a WADA test. It's a really fun test to watch if you ever get a chance to see one. This was used for pre-epilepsy surgery. It determines the lateralization of speech and independent memory in a patient, usually performed by a neuropsychologist in conjunction with a neuroradiologist as well as a neurologist. Basically, a portion of the brain is anesthetized with amobarbital for a brief period of time, mimicking a stroke. So you literally shut down half their brain. Then you test them to see how their memory is and how their language is. The test is conducted with the patient awake, so it's important if you're in the habit of consciously sedating these patients that you do not give them any drugs because it can mess up the test. Often you'll see personality changes when you're doing this. You'll see disinhibition. They often laugh when you shut down the the left hemisphere. You'll see contralateral weakness and heavy neglect, obviously, and they recover very rapidly. It's considered a safe procedure with only the normal risks of angiography. The risks are the same as with the diagnostic angiogram, and then the post-procedure care is the same. Bed rest for 2 hours with a closure device, 6 hours of manual compression. Keep your lower extremity straight if you went through the lower extremity, and again, avoid coughing, laughing, or abdominal contraction. And that's it. Thanks a lot.